Hello, everyone. Good morning, good afternoon, good evening, and good midnight, depending on where you're joining from. And today we are having a subspecialty VMR with none other than Greg. And if you have joined in a couple of times over the year, you would have seen he always shares this amazing case, and from only specialty in VMR where you could say that you have 200% success rate, and that's maternal and fetal medicine. And Greg, if you didn't, and we also have Anna who's going to be presenting the case, and this time we have Bobby who's going to be accompanying Greg in discussing the amazing case. And we are grateful for Sime for scribing and Sausan for doing the teaching points. And Greg, if you didn't mind, I'm going to hand out the mic to you, and you could say briefly about you, and then share the mic with Anna and Bobby.
Sure thing. So I'm Greg Kirshen. Thanks so much for having me back on VMR. I'm very excited to be here with my two good friends, Anna Jarvis, who's a star resident in OBGYN at Hopkins, who's applying to maternal fetal medicine right now. She's going to be a leader in the field in a few short years. And my best friend, Bobby Brar, who saw me through residency. He's a final year maternal fetal medicine genetics fellow, and I'm very excited to be discussing a case with him today.
Anna, do you want to tell us something about yourself?
Yeah, sure. Hi, everyone. My name is Anna Jarvis. As Greg mentioned, I'm a resident at Hopkins right now for OBGYN and am in the midst of applying to MFM fellowship. We get our interviews just in a couple of days, so very exciting. I'm happy to be here. And I mean, this isn't about me, but this case is a case that's very important to me. It's the case that really inspired me to want to become an MFM. From a patient that I saw during my time during residency. So hopefully it will spark an interesting and thoughtful discussion today.
Good luck with your interview, Anna.
Thank you.
And Bobby, could you just share a few words with about yourself? I think this is going to be the first time we have you on the VMR.
Yes, hello
Yeah,
everyone. I'm very happy to be here. I'm Lamia. I'm a Moroccan IMG. I just matched into internal medicine in Rhode Island. I have been a secret fan for so long, watching videos on YouTube. And finally, I'm here and I'm happy to be here with you today. Thank you.
Thanks, Dr. Lemme. And welcome to our VMR. And I'm going to share the mic with Bobby.
yeah, thanks, Kushal, and thanks for the introduction, Greg. My name is Bobby. I'll keep it relatively brief. I'm a fourth-year fellow in maternal fetal medicine and clinical genetics at Hopkins, and I've worked closely with all-star residents and Anna and Greg over the last couple of years. Done some research with Greg as well. Uh, he has a bright future in this field. And yes, excited to be here to discuss this area of interest and expertise. But I have an equal love for all aspects of maternal fetal medicine, including excited to see what we got in store.
Okay. And I just has a quick icebreaker question. I have one for each one of you. And if you could share what's your superpower or what do you have on your refrigerator door, it would be great. And I could go first. And as because I have this really bad habit of not drinking any water at all, I got a magnet saying hydrate. And my brother now got another magnet saying, hey, you, with a kettlebell saying hydrate. So that's what I have on my fridge. Bobby, did you want to go? I think you wanted to also share something on what's on your fridge.
Sure, yeah. So unfortunately, on my fridge, everything that I have is outdated. So it's a bunch of save the dates for weddings that have already occurred that I have not taken off as of yet. And then it's the football schedule for the Baltimore Ravens from last season, which is, again, not really relevant given that the new season is upcoming. So I'll have to put some new things on my fridge in the next couple months.
That sounds fun. And Greg, what do you have? What's the superpower which you would like to imbue or have?
Yes, thank you for the question, Kushal. And I like that yours is stay hydrated because I feel like in medicine we are all walking around with like a chronic kidney, injury. Um, but for me, I would say if I had a superpower, it'd probably be to have a clone of myself, just because I feel like I'm always wanting to do like 200%, and I wish I were in two places at once most of the time.
That's fun. And how about you, Anna? What's the superpower you would like to have?
It's funny you say that, Greg, because what I was going to say is that I wish I had Hermione Granger's time turner so that I could just redo things and do multiple things at once. So essentially the same superpower. I wish I could like super multitask or just, yeah, be in two places at once. This is the same reasoning. Honestly, boring, classic.
Okay, so let's rock and roll. And Simi, whenever you're ready, could you please share your screen? And Anna, you could take the mic and stage and share the first aliquot with us.
Okay, great. Let me just pull the case up. Okay, so this case today we'll be discussing, this is a 30-year-old female. She's a G3P011, and for the non-OB people, that means she's had one preterm delivery and one miscarriage with one living child. And she is currently pregnant at 10 weeks, 0 days. She presented to our labor and delivery triage for lower abdominal pain and dysuria for the past 2 days. On initial examination, she has a benign abdomen, and a bedside ultrasound was performed at this visit to assess her fetal heart rate, which was in the 170s. However, at the time of placement of the ultrasound probe, it was noted that she had large volume, simple peering ascitic fluid throughout her abdomen with floating loops of bowel and into her posterior cul-de-sac. This was a new finding for her. Her past medical history, really remarkable, only for a history of one prior C-section for a failure to progress in labor in her prior pregnancy in El Salvador. And she also reported a history of a right oophorectomy in her youth due to some sort of ovarian cyst that at the time she told us was benign. She otherwise denied any other medical history, any other surgical history, any other pertinent family history. At this point, I'll just share some of the really basic initial workup that we did, which is that we got very basic labs, CBC, CMP, and a urinalysis, all of which were normal with the exception of the urinalysis showing that she had a UTI. And her baseline prenatal labs done a couple of weeks prior in her pregnancy at the time of her initial prenatal visit were normal without any pertinent findings. So that's our first kind of block.
Wow, that's amazing. And there's just lots of rich information over there. And Greg, if you didn't mind, could you share your thoughts or what's going through your mind currently? And Bobby, also yourself.
Absolutely. Wow, this is a power-packed first aliquot. Like, it took a turn that I was not expecting, like right up front. So let's go through this case. So this is a 30-year-old woman, one prior delivery, sounds like probably uncomplicated, one miscarriage. She's in the first trimester. She's only 10 weeks pregnant. Her chief complaint is lower abdominal pain and dysuria. So, like, taking that to start, anyone coming in for a chief complaint of any variety, I always think in terms of obstetric issues and then non-obstetric issues. And I usually think of the non-obstetric issues first because I'm going to think about the obstetric issues as an obstetrician all the time. So anyone coming in with abdominal pain, I sort of think of it in terms of quadrants. So or you could think of it in terms of organ systems like GI, GU, and GYN. So if you're thinking in terms of like if she had, I don't know where the location of the pain was, if it was right lower quadrant, you might be thinking of like an appendicitis type picture. If it was left lower quadrant, you might be thinking of like a diverticulitis. If it were in the upper quadrants or the epigastrium, you're thinking maybe some peptic ulcer disease or maybe some esophagitis, or even you can also think about cardiac etiologies because that's one thing we don't want to miss in patients coming in with abdominal pain, especially women we know are at higher risk for having atypical chest pain. So that's something that's also in my differential at this point. The fact that she has dysuria makes me point a little bit away from sort of like the upper abdominal etiologies and maybe towards the genitourinary system. So of course I'm thinking UTI, and we'll get to some of the labs in a minute. We're also, we know that patients who are pregnant are at higher risk for ascending urinary tract infections, including pyelonephritis, and anyone who's sick enough to come to the emergency room or the L&D triage with dysuria and abdominal pain, that's certainly something that I want to rule out. So I certainly want to know, whether she has any CVA tenderness on exam. Um, those would be my initial thoughts in terms of the non-OB things. When you're thinking about OB causes, now I'm thinking about, could this be related to the pregnancy? So is this a threatened miscarriage with abdominal pain? Is this really more of a uterine cramping abdominal pain rather than like a GI or a GU type of abdominal pain? That's something I'd want to sort out in terms of how she's presenting, whether this pain is episodic, whether it feels like period cramps, whether she's had any associated bleeding that could suggest either like a threatened or an ongoing miscarriage. We didn't get that information, so I'm assuming she hasn't had bleeding. So that's something I'm thinking about. We get to the benign abdominal exam, so that's good. That's another thing you want to think of as obstetricians, we're also surgeons, so we want to make sure is this an acute abdomen. We didn't get her vital signs, but assuming they were normal and she has a benign appearing abdominal exam, now we have more time to kind of think about what our differential is, what we want to do next. If she had a surgical abdomen, especially if she has a history of an ovarian cyst, which we'll get to, you might be thinking this could be an ovarian torsion case, in which case that's a surgical emergency. She needs to go to the OR whether or not she's pregnant, to try to save that remaining ovary because she only has one left. Those are my initial thoughts in terms of her chief complaint. We get to the fetal heart rate. Now that's actually a little bit abnormal. The typical fetal heart rate you're going to see is like 110 to 160. Early in pregnancy, like the first trimester, it can get up to like 170, like high 160s. That's something that's a little bit unusual. I wouldn't say it's like completely abnormal, but it's a little pushing the upper limit of normal for 10 weeks, but not something I'm typically, I'm following too closely at this moment. Other than, possibly she could have a little bit of dehydration can cause fetal tachycardia, or sepsis is another etiology. Then the main finding of this aliquot is the large volume ascites. So that is completely abnormal, whether or not you're pregnant. That's something that I'm going to be very closely tracking as we hear more information. I would say, when I'm thinking about approach to ascites in general, I'm thinking, is this cirrhotic or non-cirrhotic ascites? And then, we can use like the serum albumin ascites gradient to help us kind of differentiate if the gradient is greater than 1.1 or less than 1.1, which we can probably get to in future aliquots. Then just kind of running through the rest of her history. She had one C-section in El Salvador. I don't think that's particularly relevant. She had a history of an oophorectomy for a quote-unquote benign cyst back in her youth. That was outside this country. So, I of course want to see the operative report if it's available. I'd want to see the pathology report. Interestingly enough, there's a condition called Meags syndrome where you get either unilateral or bilateral ovarian fibromas that can usually gives you pleural effusions, but can also give you ascites. So that's something that, if she had a fibroma, that might go with this, or it could be completely unrelated, given that this was such a long time ago. Then we get to her labs. Her UA shows some evidence of UTI. So again, that's, could it be a red herring? Possibly. But, could it be related to her presentation? I'm trying to link, dysuria, UTI, and ascites, and nothing is particularly coming to mind. If she had recent surgery, for example, there could be like a ureteral injury or bladder injury, and then you can actually have urinary ascites that can, give you both like a kind of abnormal urinalysis as well as what appears to be ascites. But it doesn't sound like she's had recent surgery, so that's sort of lower on my list. And I'll stop there. I'll hand the mic over to Bobby.
Yes. So, um, uh, first off, I'll say that I agree with Greg's important, and this is partially based off personal experiences. We have some information about the ultrasound. I would take a closer look at the ultrasound, perhaps do the ultrasound myself, and I would want to confirm that even though we have a fetal heart rate in the 170s, one thing that you want to keep in the back of your mind is this could still technically be an ectopic pregnancy. Now, an ectopic pregnancy in the tube, probably not going to make it to 10 weeks and present in a ruptured state like this. However, I have seen a handful of patients in my career that have corneal ectopics or ectopics in other places that rupture that make it, this far along that were mistakenly diagnosed as IUPs early on. So that's something that you want to do a detailed ultrasound of, because that would obviously impact how you would manage the pregnancy as well as the acute situation. The other thing is Greg mentioned that there are some obstetric causes that can cause acute pain. One thing that I think he forgot to mention would be like a degenerating fibroid can cause acute pain. So I'd want to see if she had a history of fibroids, see if there was any fibroids on the ultrasound. Certainly, I wouldn't expect a degenerating generating fibroid to cause ascites in the abdomen. So that perhaps makes that a little less likely. But when you have something like this that seems atypical, you're trying to go through all of your entities on your differential, even as unlikely as they may seem. The last thing to point out would be that there was no mention of this being an IVF pregnancy or the patient taking any ovulation induction agents. And so I'm going to take that at face value that that was not present in this case. But if you see someone that's had a prior oophorectomy or if they've had a history of infertility, certainly if they are taking those agents, one thing that can present like this is ovarian hyperstimulation syndrome, which classically presents as someone that comes in a fluid overloaded state after having gotten a ton of induction. And those patients can get very, very sick, get admitted to the ICU, and require quite a bit of careful fluid management. I think that's mostly everything. Maybe maybe a molar pregnancy would be the last thing, but that again goes with looking at the ultrasound HCG, which we don't have the HCG yet. But again, I'm taking this at face value that this is an IUP and not any sort of misdiagnosis. But in a molar pregnancy, you can see kind of a preeclamptic type picture as well, especially with a complete mole. And so that would potentially also present with a kind of a fluid overload state like this. But that's all I got.
Thanks a lot for this extensive list and all the thoughts which have gone through your head now. And then we are ready for your next second report, Anna.
Okay, great. Yeah, that was an awesome overview, y'all. A couple of things. So, now once we had done her initial workup, I will say her abdominal pain entirely resolved with a dose of Tylenol in our triage. And we started her on treatment for her urinary tract infection based on the UA. We then did obtain a formal abdominal ultrasound of this patient to assess her other intra-abdominal organs, which was notable for moderate to large volume, simple appearing ascites in right greater than left lower quadrants, but otherwise completely normal findings, including a normal liver size and echogenicity, a normal gallbladder, common bile duct, and a patent main portal vein. At that point, our team did reach out to our gastroenterology colleagues in the hospital, and they just recommended outpatient follow-up, diagnostic paracentesis, and hepatology follow-up as an outpatient. So she was discharged with treatment for her urinary tract infection and follow-up scheduled. She did obtain a paracentesis, which I'll discuss the results from in a moment, as well as followed up with hepatology as an outpatient. So the results of her paracentesis, her SAAG was less than 1.1, that ratio, and the total protein was 5.4. One of the culture tubes grew gram-positive cocci, although her ascitic neutrophils were less than 15%, and she herself had no infectious symptoms by the time that she was there for the paracentesis and did not have any abdominal pain. Her fluid cytology, CEA, and AFB tests were also all negative. And she did have an informal transvaginal ultrasound that was performed then around the same time at one of her prenatal visits that was done by an obstetric provider that could not visualize a right ovary and thought that they saw what appeared to be a relatively normal appearing left ovary, although was limited by patient discomfort with the placement of the probe. And again, they still saw the ascites at that time.
Bobby, with the rest of the information now, which has been given about the ultrasound, what are you thinking of, and what's your differential and top two or top differential, and would you like to do any treatment specifically based on that?
Yeah, thanks for the question. I still, the additional information is certainly helpful. I still would like to see a little bit more on the pregnancy specific component of the ultrasound to rule out some of those, certainly the ectopic as a differential. So that's something that I would like to know. In terms of top, I think that going back on Greg's differential in terms of thinking pregnancy-specific disease versus non-pregnancy specific and GI more specific causes of ascites, I would say I'm at this point leaning towards the latter. But I still think we need more information and certainly input from our GI colleagues. I don't know if you had any other thoughts, Greg.
Yeah, no, that's a great discussion. My other thoughts, I totally agree with what you said, Bobby. the SAG helps us a little bit. So the albumin ascites ratio being, or the serum albumin ascites ratio being less than 1.1 points actually away from portal hypertension, I believe, and would point more towards like either like malignancy or like infection. Like I'm thinking, especially the patients from El Salvador, could this be TB? Although I think I heard Anna say that she had a negative AFP, which might suggest against that. But I would still want to culture the fluid. It sounds like one of the tubes might have had some bacteria that was potential contaminant. I'm not sure what to make of that. But I'd want to do like a longer term culture because we know that TB takes longer to grow out than a typical bacterial culture, just to see if that might give us some clues. I agree with Bobby that I'm pointing towards, away from an obstetric etiology most likely at this point. And again, given her history of an ovarian mass, I think ovarian cancer is certainly on the differential for anyone presenting with new ascites with a history of ovarian mass in the past. Um, Although we don't, see the left ovary looks normal apparently according to the ultrasound.
And I forget again, was this IVF or just a normally conceived pregnancy? I think that was a question which.
Yeah, it was a spontaneous pregnancy, so no ART for this pregnancy.
Okay. And the other question which I did have was that if you didn't mind me asking, what medication did you guys give to treat her UTI?
Yeah. She wound up just getting treated with 5 days, I believe, of Keflex, which just for a simple cystitis for her.
Okay, great. And then we are ready for the next eloquent.
Okay, perfect. And also in response to Bobby and Greg's question, I will say amongst this time, she did have a formal MFM ultrasound that confirmed that she had a normal intrauterine pregnancy that was developing normally at that point. I think around this time, after she had gotten her paracentesis and kind of all these results came in, she at this point was maybe 12 or so weeks pregnant. And we actually called her back into labor and delivery triage because we also didn't know what to make of the bacteria that was growing from her paracentesis and just wanted to make sure that she was still doing okay. And so we did bring her back into triage. She overall was asymptomatic at that point, but based on our concerns, given the ascites and her ovarian cyst history, we did obtain a CT abdomen pelvis of this patient. Her CT scan was largely unremarkable. It noted more ascites. And then interestingly enough, bilateral corpus luteal cysts is what the CT scan read said. A little bit difficult to appreciate on our own read of this. Otherwise, she also had a trace right pleural effusion. We had been also coordinating her care as an outpatient at that point, and she had gotten cell-free DNA that was low risk for any of the genetic abnormalities that it screens for, as well as for any concern for malignancy, since that's kind of a side use that you can for cell-free DNA as well. She also then, we coordinated in the following week a pelvic MRI to really fully assess her adnexa. For any folks who know about radiology, CT scans are not a great way to assess the adnexa. And so getting that MRI we thought to be very helpful. Unfortunately, the patient just could not tolerate sitting in an MRI. And so that study was not helpful for our diagnostic purposes. She followed up with hepatology during this time as an outpatient, and they were largely stumped by this case as well. They recommended a chest x-ray just to assess for any concern for possible heart failure or cardiac etiology, cardiomegaly. Unsurprisingly, she had mild cardiomegaly on her chest x-ray, and she did then get an echocardiogram that was done that was normal. And she continued to be relatively asymptomatic during this time and maintained a low salt diet and daily weights per her hepatology recommendations. At this point in her pregnancy, she's nearing term, but continuing on with an otherwise uncomplicated pregnancy.
Greg, it's your turn. What are you thinking of and what are you concerned about?
Yeah, so we learned that this is a normal intrauterine pregnancy, so we rule out ectopic, which is great. That's one of our things that we can't misdiagnosis, life-threatening potentially. So I'm glad that this is a normally developing fetus, we think. Her symptoms have gone away, although it doesn't sound like she ever really had symptoms that were particularly related to the ascites, even though it's large volume, which is interesting. We do have some positive pieces of data here with the CT. We do see bilateral corpus luteum cyst. I mean, typically with a normal pregnancy, you're going to expect one of the ovaries is going to have a corpus luteum cyst. It's interesting. She's actually had an oophorectomy, and we have a cyst on the side where her ovary came out, that kind of raises red flags for me. Like, could this be an ovarian remnant that has, somehow become a malignancy, or, some other non GYN pathology that we think looks like a corpus luteum cyst, but is actually, potentially like a GI malignancy or like a GU malignancy. Those are certainly possibilities in someone who has had a oophorectomy. We often, whenever we do an oophorectomy, we usually take the the ipsilateral tube as well, so the tube and ovary come out. So I really wouldn't expect any adnexal pathology on that side specifically. So that was sort of curious to me. We see that she has a trace pleural effusion on the right side, which, again, I still am not confident that she doesn't have an infection or malignancy. Those are certainly still very much on the differential for me. And, those are things that I would want to be evaluating for further. Her cell-free DNA was normal in terms of so what it can tell you is sort of like the correct number of chromosomes are there. In terms of, you don't have triploidy, for example, which could be seen in a molar pregnancy. Um, and then low concern for malignancy, we're starting to use cell-free DNA now, although it's not really, standard of care to see if you have circulating tumor DNA that can actually pop up in certain malignancies, and that can help be diagnostic. But a negative test result doesn't reassure me. A positive test result might lead me to go more exploring, but I'm not necessarily reassured by her cell-free DNA not showing any signs of malignancy. It's unfortunate that her pelvic MRI couldn't be completed, because I agree. I think that would have given us additional data on what this potential, what's being called the corpus luteum is. Although, you have to deal with the constraints of reality. And then, in terms of her cardiac evaluation, I think that was very appropriate. You want to make sure this isn't cardiac ascites, although her SAG would suggest it wasn't, but, you still want to be careful. She does have a little bit of cardiomegaly, which, at 12 weeks is a little bit unusual. I want to know whether this was an AP or a PA film. Although her TTE was reassuring, I'm assuming she has normal ejection fraction, no structural issues. This isn't like a case of congenital heart disease that was undiagnosed because she's, hasn't had care and that kind of thing.
I'll just add just a couple of things. I again agree with Greg in this in the setting that I think that right now differential probably favors infection versus malignancy as the leading likelihoods. Things just kind of mentioned that he and just add on that he has already touched upon. Cell-free DNA is, we're still learning. We're in our infancy in terms of learning about how well it screens for cancer. There are some studies out there that show that some people are using it in the non-pregnant population as a pregnancy screening test. That has not been clinically validated and something that people would routinely use. The other thing I'll say is that when we do pick up a cancer on cell-free DNA screening, those are most likely to be lymphomas and leukemias rather than solid tumor malignancies. And so one could argue that perhaps those might be less likely to present with an ascites type picture. The corpus luteocysts, interesting. Like Greg said, they're there in early pregnancy. They're there to support the developing pregnancy, usually resolved by around 12 weeks. If we didn't have such a convincing story of a normal ultrasound, this really kind of seems to fit the high HCG hyperstimulation picture, because in cases like ovarian hyperstim and molar pregnancy, you can have elevated HCG that actually causes theca luteal cysts that can potentially look like a corpus luteum on ultrasound. I will say that in doing ultrasounds every day, all day of normal pregnancies, we don't usually pick up these corpus luteal cysts, even though they're present, especially bilaterally. And so that's very unusual in combination with the ascites. So again, the objective data suggests against a pregnancy-specific cause. Certainly not an ectopic, it sounds like. But I'm kind of curious whether there's some other cause of elevated HCG. Is there an undiagnosed twin? Is there an HCG secreting tumor? Is there something that's causing there to be this hyperstimulation? Still would have infection and malignancy higher though. So.
I just had one question for someone who's not really practicing OBGYN. It's been a while since I did deliver a baby. And so how concerned are you for her? I mean, is it safe for her to continue her pregnancy, or is it a conversation you would have with her now? Or it's not something you're worried about?
Yeah, I think that largely depends on the etiology of this ascites. Based off what we know right now, I would say that there's no increased risk based off ascites alone. If we find out that there's an infection that can be passed down vertically, we would counsel her on that respective infection. Certainly, if malignancy is present, depending on what the malignancy and treatment is, we would have to discuss in collaboration with our oncology colleagues on what when would be the best time to give chemotherapy and kind of weigh the risks and benefit of continuing versus not. And so, yeah, maternal ascites in and of itself is not a contraindication of pregnancy, but it's often associated with diagnoses that can make pregnancy very dangerous for someone.
Thanks for clarifying. Did you have anything else to add, Greg, or are you ready for the next aliquot?
No, that was a brilliant discussion, Bobby. I think we're ready for more information.
Okay, great. Just a couple of extra tidbits I'll add in response to a couple of the points y'all have made. I will say we did refer her to our GYN oncology colleagues during this time, just for an evaluation or any additional recommendations for workup that we could do. They saw her in clinic and reviewed her CT scan and discussed and examined the patient and essentially just recommended evaluation at the time of her planned repeat C-section of her adnexa, but no additional recommendations, and their concern for any sort of ovarian malignancy after reviewing her CT scan was quite low at that time. Although I will say that did remain quite high on our differential as well, given the acuity of that diagnosis. So at this point, she is essentially nearing term, has continued her pregnancy without really anything additional. Her ascites itself has remained roughly stable on her low salt diet, and she's seen hepatology throughout the pregnancy. The only thing that really came up additionally during her pregnancy is one more urinary tract infection. And then after this, she was started on ongoing suppression. So she took a low dose of Keflex every day after about 18 or so weeks because of the second urinary tract infection. But at 39 weeks, she presented to our labor and delivery triage again with painful contractions, and she was noted to be dilating, so suggesting of labor. Given her desire for repeat C-section with a history of one prior C-section, the decision made was to proceed with her C-section at that point. Her delivery was overall uncomplicated. I do have her operative report findings that I think are somewhat interesting, which is that upon entry to her abdomen, they noted just about 150 cc's of straw-colored clear ascites. They did do a brief peritoneal analysis for what they could via the fan and steel. Actually, I think they used her midline vertical incision. I apologize, that she had previously before, although it was infraumbilical. And her peritoneal surfaces appeared normal. The bowel that they were able to see appeared normal. Her uterus itself had these kind of small red pinpoint lesions and some small adhesions that could be related to prior surgical change or operative manipulation, but also was thought at the time to be potentially signs of endometriosis. Her right fallopian tube and ovary were surgically absent, consistent with her story of having an oophorectomy or a salpingo oophorectomy prior to this presentation. Her left fallopian tube had these kind of bright red firm fimbria, and her left ovary overall appeared normal, but had a small 2-centimeter cystic structure that was protruding that they did perform a cystectomy on in as contained a fashion as possible. She also desired permanent sterilization, so her left tube was also removed, and the remaining left ovary was left in situ. Postpartum, she did quite well without any issues, and her pathology resulted with benign and normal left fallopian tube, and her left ovarian cyst was noted to be a benign corpus luteal cyst without any significant findings. They didn't send the ascites or anything else at the time of her surgery.
So, Bobby, the operative findings of red pinpoint lesions on the uterus and left ovary, would that be like endometriosis, and could that be the cause for the abdominal pain itself? Are you worried about that, or what are your thoughts?
So yeah, I mean, it sounds like it potentially could be endometriosis in terms of what those operative findings were. I'm not aware of endometriosis being associated with large volume ascites, not usually something that causes pain in pregnancy per se, unless someone were to have an endometrioma that was large and torsing or rupturing or something of that nature. In addition to that, this is just kind of an aside, but people with endometriosis oftentimes have infertility and difficult times getting pregnant. So that would kind of go along with if she was getting stimulation, potentially this being a hyperstimulation type story. The only thing I'll say in terms of talking about her obstetric care, I know Dr. Jarvis said that she had one prior C-section. I'm curious whether this is someone that just wanted a repeat because she didn't want to, a repeat C-section rather than a trial of labor because she didn't want to incur the, the risk of uterine rupture, or whether this was planned as a part of a kind of a diagnostic exploratory laparotomy in conjunction with her C-section. Personally, I think it's a good idea because, we have that discussion with all of our patients with one prior C-section, whether they want to try vaginally or have a repeat, but certain times in some instances, there are factors that strongly support one approach versus the other. I think in this case, you guys did the right thing in terms of getting more information at the time of her C-section as an added benefit. I don't know whether the operative findings change our differential all that much. I guess we can say that an ovarian cancer would be, much less likely with the pathology findings of the corpus luteal cyst. Certainly, you don't rule out all other types of malignancies by just doing an exploratory laparotomy like this. And so, helpful information. Not quite sure we have our answer quite yet, though. I'll let Greg give his 2 cents.
Thanks, Bobby. That was a great discussion. I totally agree with you and Anna and the treatment team to take this patient for a repeat C-section. Unless she very strongly desired a vaginal delivery, I think you get a lot of information. I think it can be challenging to coordinate these cases with GYN oncology because these patients could be coming in labor in the middle of the night, and you want them to be present so that they can, as Anna said, examine the peritoneal surfaces, take any biopsies of suspicious lesions. I would definitely not be comfortable as a general OBGYN or as an MFM removing a cyst off a potentially malignant ovary. Typically, as Anna was alluding to, we don't want to have any spillage of ovarian contents because that can actually upstage an ovarian cancer if it does turn out to be cancer. So if we're going to be doing a cystectomy because the patient's only 30 years old and she only has one ovary left, I would certainly want that to be done by a GYN oncologist in this case. Thankfully, it was benign. I agree with Bobby. It doesn't give us too much information pointing towards like an ovarian malignant etiology for her presentation. However, it does rule out, or make us less suspicious that this is like a primary ovarian process. What else do I want to say? I think the red lesions on the uterus, I agree, could probably be proliferative endometriosis. I don't know if any of them were biopsied, but that would certainly be a possibility. Versus, residual scar tissue from a prior C-section that can sometimes be opened up as you're entering the peritoneum. Those are some of my thoughts. I think, you know, certainly spontaneous ovarian hyperstimulation syndrome is a differential that I would entertain. I've never seen it or heard of it, but this certainly could be like a case report of a spontaneous OHSS picture, given that really we haven't had anything else to suggest that. If you are thinking that OHSS is on your differential, you can always check a VEGF level because we know that VEGF is highly upregulated in these cases, and not typically super upregulated by pregnancy itself, so that might be helpful. So those are some of my thoughts.
We have one interesting question in chat if anyone wants to take it. Does endometriosis usually remit during pregnancy?
Yeah, it's interesting. So pregnancy itself is a hyperestrogenic, hyperprogesterone state. So we do sometimes see remitting of symptoms of endometriosis in pregnancy. That's certainly a described phenomenon. Not all cases will have remitting symptoms during pregnancy, but we treat endometriosis with estrogen and progesterone outside of pregnancy. So sometimes those pregnancy hormones can help us out in terms of relieving symptoms. Just on a kind of commenting on a surgical level, we do think about endometriosis as potentially posing surgical risk when we're performing a C-section, especially if someone has, later stage, like stage 4 endometriosis, where the uterus is very adherent to bowel. We worry about bowel injuries. We worry about being able to even access the uterus sometimes to deliver the baby safely. So depending on the severity of the endometriosis, that can actually affect our surgical planning. And that isn't something that I would say necessarily gets better with pregnancy. The symptoms may remit, but I usually don't think of like pregnancy as curing all the endometriosis lesions and scar tissue.
I just want to quickly, I think the person before that asked a question about could this be PID causing ascites and Fitzhugh-Curtis syndrome. PID is incredibly rare during pregnancy for obvious reasons. There's a space occupying lesion that happens to be the baby that's preventing a sending, morbid infection. It can occur though, and usually would be something that would necessitate inpatient management. But they would clinically have more of a picture that was consistent with potentially cervical motion tenderness, severe abdominal pain, oftentimes fevers, a leukocytosis. Now, leukocytosis can be mildly present in pregnancy, but you're going to see more of an infectious type picture and process, especially if someone's going to have PID to the extent that it's causing ascites and liver capsule adhesion. So it was a good thought by whoever posed that question. Certainly, I can't say that it's impossible, but I would say lower on my differential.
Perfect. Anna, do you have another aliquot before the diagnosis, or?
No, that's kind of all. I mean, I will respond. I think there were just a couple of things. I'm trying to remember that to your point about mode of delivery for this patient, I think it's a really important point, Bobby, I think that you made about why, whether, I don't remember which one of you, I guess, said whether this patient would trial labor versus have a repeat C-section. She actually just strongly desired a repeat C-section and did not want a trial of labor based on her prior experience with labor in her last pregnancy. So I think that in some ways we kind of really got off lucky on that too, because I think it gave us this opportunity for an exploratory laparotomy, and the patient was very much in agreement, and it was in alignment with her own goals for the pregnancy, which I think worked out very nicely in this case. But I don't have any other specific diagnostic material to give you. So do you want me to talk a little bit more, Kuchal, or?
Oh, yes, please.
Okay.
What were your takeaways from managing this patient?
What I will say is that we don't have a super clear diagnosis for this patient. So in some ways, it's a little bit of an unsatisfying case. She's wound up doing very well postpartum and actually has had no ascites since delivery of her baby. It has since resolved. She followed up with hepatology, and they discharged her from their service. And she's had good follow-up with her OBGYN and is now back and having kind of routine GYN care at this point. I mean, I certainly have what my leading differential diagnosis is at this point, because it's the best I can come up with, but we don't have a clear diagnosis, unfortunately, in this case. I just think it's a fascinating case.
What are your takeaways from the whole case, Greg, and also Bobby?
Yeah, well, first of all, this is very real world. Like, we don't always get the slam dunk diagnosis at the end. Sometimes we have these unsatisfying cases. I mean, I'm glad that the patient's doing better. The fact that the ascites resolved after the pregnancy, to me, hints that maybe it was pregnancy related. Um, but again, nothing else kind of popped up as grossly positive to where we can really put our, money down and say that there was a clear infection, a clear malignancy. Certainly, if there is a malignancy or infection or autoimmune process that's leading to ascites, I would not expect that to get better after pregnancy. So that sort of rule like points me away from those things. In terms of take home points for the case, I think Bobby mentioned it right up front. Like, don't assume anything. Like, make sure it's an intrauterine pregnancy, not an ectopic pregnancy. When you see ascites, like, make sure that's not blood in the cul-de-sac. That could certainly be a ruptured ectopic pregnancy. I like the idea of this could be a molar pregnancy. So starting to think a little bit outside the box, because ascites is a very unusual finding in pregnancy. Preeclampsia, I think Bobby had alluded to, can certainly cause ascites. I would not expect that at 10 weeks gestation. We usually see that later than 20 weeks at the earliest, and usually third trimester. And you can see, I wouldn't say large volume ascites, but certainly small volume ascites at the time of C-section, for example, is something that's not completely atypical in patients with severe preeclampsia. That would certainly be a differential that I would entertain. But yeah, definitely a challenging case, and I really appreciate you, Anna, for presenting to us.
Yeah, I agree with everything that Greg said. I think we can all agree that whatever this patient had was likely a pregnancy-specific process. When we think about a lot of diseases that are pregnancy unique, whether it's gestational thrombocytopenia or cholestasis of pregnancy or preeclampsia or anything that's really caused by the pregnancy, oftentimes the cure is delivery, removal of the placenta, and oftentimes, if it's HCG mediated, resolution of high HCG levels. And so when we see something like this, where we have ascites, starting to kind of coincide and get, it seemed like it was at its worst at the time when the HCG levels were the highest at around 10 weeks. So that almost suggests that this was a stimulation of some sort. Now, again, that doesn't usually happen with, just baseline normal high HCG levels. So something was providing an extra kind of impetus behind this hyperstimulation. So I would say that that's kind of my new most likely diagnosis given the resolution. In terms of other takeaways, yeah, everything that Greg said, he hit it on the dot. Maintain a broad differential. I think that for those of you that are non-OB providers, and work in more of a primary care setting, when people are pregnant, there is a tendency to just say, "Oh, this is unusual. It must be the pregnancy." But when people are pregnant, especially young reproductive age women, they very commonly get, affected by the same sorts of disorders that affect people that are not pregnant, whether that's appendicitis, whether that's infection, cancer, et cetera, et cetera. So maintain a broad differential. Our role as providers is to help inform how processes that are unique to pregnancy. But I think that this is a case that was managed well. I think, I'm happy the patient had a good outcome. And I think that it certainly gave us a lot to think about and talk about in terms of going through pregnancy and non-pregnancy related causes of fluid overload and ascites. So yeah, Anna, great job. She's definitely going to be a great MFM doctor and certainly a rising star in our field. So thanks for having me on.
I just have a couple more questions, actually, two. One of them was in the chat, and then one of them is asking whether it could be a choriocarcinoma. Would you still want to examine the placenta very closely in this case? And the other one, I can share it after you discuss this. Yeah.
Yeah, yeah. Oh, sorry. Go ahead, Bobby.
Yeah, choriocarcinoma actually is a interesting thought, because that's a tumor that would secrete HCG, and that's a tumor that would explain everything that the patient was going through during the pregnancy. Now, choriocarcinoma, the one thing that I think would again lean against that would be the fact that this got better right after delivery. Usually choriocarcinoma tends to be something that is circulating in the blood, oftentimes does require extensive treatment, whether it be with chemo or, if it's associated with a molar pregnancy, even hysterectomy at times. So, it never hurts to send the placenta to pathology when you have an equivocal diagnosis as such. But I think that that's one of the, certainly one of the things that can cause a unusually high level of HCG, but I don't think this was choriocarcinoma.
Yeah, one point I'll add, and I actually just saw a recent case of this. You might have seen it too, Bobby, sometime in fellowship. We had a co-twin molar pregnancy. So one twin was completely normal, developing gestation, and the other was actually part of the placenta. Um, so I would definitely send the placenta in this case. Choriocarcinoma is one differential, but certainly a coexisting co-twin molar pregnancy is something that I would also entertain.
That's very interesting. And I had two questions, since we did bring about VBAC, mention it a couple of times. And I do remember, like, the midline incision on the uterus is a contraindication for it. And but can you just go over VBAC and whether it's going to be safe for this patient to consider pregnancy or having another child in the future?
Yeah, absolutely. So typically, when we think about who is a candidate for a trial of labor after cesarean, or what we call a TOLAC, and then the success would be a VBAC, vaginal birth after cesarean, the factors that we consider are as you alluded to, where the prior C-section scar is, and how many C-sections they've had in the past. So those who are a candidate for a trial of labor after cesarean are those who've had what we call a low transverse incision on the uterus. So it's a kind of side-to-side incision in the lower uterine segment. The reason being that the risk of uterine rupture is incredibly low in that case. It's around 1%, which isn't zero, but uterine rupture being a catastrophic outcome, it's something that we really have a very low risk tolerance for in obstetrics. Anyone who's had, as you alluded to, a what we call a classical incision, which is up and down incision on the uterus, does not refer to the skin incision, but actually the uterine incision itself, as you said, or anyone who has had what we call a mid-segment transverse incision, where the incision is high up on the uterus, even though it's side to side. Those are typically not candidates for a trial of labor after cesarean because the risk, exceeds what our risk tolerance is. And then also typically patients who've had more than 2 prior C-sections, even if they were both low transverse, most people would not offer those patients a trial of labor.
And the next part of the question, do you think it's going to be safe for this patient to consider pregnancy again, or would you recommend or advocate for her to for contraceptive measures?
I could start that one. I would say, we don't really know the etiology of her condition. It seems to have had a relatively benign course, however. She seems to be fine afterwards. It seems that whatever this process was not life-threatening, at least from the information we have. It didn't affect her hemodynamics. It didn't affect her labs. It's not like she had, laboratory derangements where she had, kidney injury or liver injury, where I'm worried that this is affecting her health adversely. So I think I'd certainly want to be vigilant in a future pregnancy. I would probably, keep my GYN oncology colleagues on board early on in this pregnancy. I would also consider a reproductive endocrinology consult, given this, has sort of a flavor of OHSS, to get their input and see if there's any kind of considerations preconception that they would consider for someone who you think might be prone to a spontaneous OHSS. Those are sort of my thoughts.
Yeah, I agree with Greg. Certainly not a contraindication of pregnancy. The fact that she had ultimately a positive outcome and resolution would be positive prognostic indicators. I think when we talk about people who get sick in pregnancy and talk about recurrences, a lot of that is derived from our cardiac literature, where we see people get, have certain cardiac lesions. They don't tolerate pregnancy well, and then we tell them, well, if your heart function didn't recover, in certain cases, like patients that have a very dilated aortic root with Marfan's, or patients that have pulmonary hypertension or peripartum cardiomyopathy that doesn't resolve, we tell them, we do not recommend that you get pregnant again. This patient does not fall in that bucket. And I think that I agree with Greg on the REI consult. I think if this patient ever had a difficult time getting pregnant, I would proceed with extreme caution in terms of giving her any types of ovulation induction, because we know that she would be incredibly sensitive to such agents. And so, of course, I wouldn't pretend to masquerade as an REI doc and say that that would be contraindicated, but I would surmise that that's something that would have to be discussed in terms of the risks and benefits.
For sake of time, is there anything else you want to add, Greg, or?
No, I just would love to come back here again. I had a blast. Thank you so much, Anna. Thank you, Kushal, for mediating. I appreciate everyone's input. I think this is a fascinating case. A little bit dissatisfied we don't have an answer, but that's how life goes sometimes. But again, I really enjoyed my time here, and happy to be here again.
Yeah, we're happy to have you too, Bobby and Greg. And did you want to say something, Bobby?
No, I was just gonna say, yeah, we would. I forgot to say that we would love to be back next time. Maybe let's do a genetics case so we can talk about some good fetal issues too. And I think there's a lot to learn from everyone. And thank you so much for the honor of being here.
Thanks a lot, everyone, for tuning in, and hope to see you all soon. Have a great rest of the day. Bye-bye.